So if I tried to introduce these guys for this, we would use the whole 35 minutes of conversation. These guys have been in there a long time and they've created many things over time. So I'm going to try to use this time wisely. I'll start with the old timer, Dr. Jeffrey Cohen. So he is a serial disruptive entrepreneur in medicine and science field. He's practiced 40 years in neurology and specialized in oncology. Again, he has leadership positions with one of the largest integrated health networks in the nation. He has given us over a 360-degree understanding of economics, clinical, social issues, and impact into the American healthcare system. He currently holds over 30 patents. He has worked in the private sector. He's been a successful entrepreneur and venture capitalist. He's a CEO now of one of his companies, which is ChemImage. He's also a leading innovator in the community health of Allegheny Health Networks. And I could go on, but we have to continue. Our next distinguished person on our panel is Dr. Adam Saltman. He's both an MD and PhD. It's always tough being the dumbest guy in the room. And with you guys here, it's really shining on how dumb I really am. But again, he is the Chief Medical Officer and Regulatory Officer of ChemImage. He's a board-certified cardiothoracic surgeon. He has more than 25 years experience in managing complex patients with multi-morbidity and comorbidities. Before Chem, he was a Chief Medical Officer. He's a Harvard graduate, a Columbia University graduate with his master's, again, certified in advanced studies with Chicago, Illinois. He's a board-certified general surgeon, thoracic surgeon, and clinical informatics. Okay, that's a lot. And then we have Anthony Cohen. He's currently the Connective Care and Digital Health Solutions Leader for Respiratory Care Business. Again, Philips, he is the lead digital health SAS and SaaS and medical devices within Philips. His extensive experience in solution development, global product management, and operational lead. Over the past 14 plus years, he's focused on positive effect outcomes. So we have a really strong group here, I think, to kind of talk about consumer health. So the first mission is, how do we define consumer health? We will begin with defining is, who is going to pay for it? Let's get to the ground roots. Today, the majority is not the patient. It's fragmented. We have payer to employee, we have healthcare provider to patient, and payer to patient. The payer to employee is becoming too great of a financial burden for many companies. Thus, the burden to our employers, us, becomes the burden of healthcare. It is rare to have patients pay out of pocket versus health insurance coverage. So, additionally, as we define this, healthcare can be defined as fee for service, which we'll discuss sustainability in our panel today. As a foundation and based on defining consumer health, who pays for it, my first question is, we can begin by asking the panelists, how do you see the current state of payer behavior and consumer behavior with respect to each other? Dr. Cohen, would you like to begin?
Sure. Nice to be here. I'm going to start with a little bit of history because it's appropriate that you're sitting in the Simmons Auditorium. Richard P. Simmons, Nick Simmons, is a friend of mine. He was president of Allegheny Ludlam Steel. The first group policies were actually between the United Steelworkers and Blue Cross of Western Pennsylvania. And this model started in the 50s because you couldn't write 600,000 policies at that time. They were group policies. And this model evolved since the 50s. It's about 70 years old. And it reflects the manufacturing age of which Pittsburgh was ground zero. So the model that we have today is a fee-for-service model, which started with you come in for a procedure, we pay you X amount. There weren't that many procedures at that point. And the evolution of healthcare over the last 70 years has changed the way healthcare is practiced. And today, it's about 18% of the GDP of the wealthiest country in the history of the world. So what do you get for that money? Well, right now, there's a lot of problems with it, but still, most of the innovation in the world starts in the United States. And the money that's being spent on healthcare is divided into two different payment systems. One is fee-for-service, which Steve talked about, otherwise known as the more you do, the more you make. And every hospital administrator, including myself, would say, I want you to bring me more patients in the fee-for-service world. 51% of the payment system now is a direct payment from the federal government. That's called a value-based system, meaning that I want you to fix this and keep them out of the hospital. So you have two different economic incentive systems at play here. And we're reaching a point where we can't continue both. First of all, as a physician, you're driving us crazy. Okay? Do you want more patients or do you want me to get them out of here? So we started looking at this in great depth and found some very interesting things. We've modeled this after several different healthcare systems. Every Medicaid patient that's admitted, we lose thousands of dollars. And there's a small percentage of those patients where we lose 4 times the amount that we lose in the commercial system. In the commercial world, we make money on every patient that we have. So if you don't have the net income that comes from the commercial world to subsidize the Medicaid world, you got a problem. Your hospital's closed. Oh, by the way, since 2010, over 1,000 hospitals, I'm told, have closed or consolidated. So you're seeing the beginning of a process that's very familiar to the Pittsburgh region called creative destruction. And it started with the steel industry in the 70s, and it pretty much culminated by the 80s, where you didn't need 5,000 people to make steel. You needed 250 of them that had masters. And we're sitting at Carnegie Mellon University, which was the donor. It's kind of ironic that we're sitting here. And Dick Simmons donated this auditorium for the purpose of understanding the process of creative destruction for healthcare. So the present model that we have is not sustainable. The employers are being taxed twice for the care of the patient. One, they pay their federal taxes, both personally and corporately. And number two is they're subsidizing the care. And when the insurance companies look at what they're paying and what they're getting, they're going, wait a minute, why can't you do this with all the patients? I'm going to let you in on a secret. It's not the fact that you get paid less for taking care of Medicaid patients. It's they consume more resources. And on average, they consume twice as much of the resource pool as does the fee for service. So the message is that the current model that we have is going to change as healthcare changes. And it comes down to who's paying for it. So you okay there?
Yeah.
We got a doctor for you too. So the bottom line is that you're in the middle of the process of creative destruction of healthcare, but it's a fundamental institution of community that needs to continue. So as we evolve through this, it's no secret, hospitals aren't making any money. And the money right now is sitting at the payer level. And the model today is that an employer who has employees buys a policy from an insurance company. An insurance company contracts with a provider system to take care of patients. The patients are also known as employees, and they're also known as voters. And you have multiple different stakeholders in this process that you have to figure out how they're all going to live together without killing each other. So when the person comes in as a patient, they usually don't pay, they pay a small fraction of what the total bill is. And the bill is more a function of what we can get away with charging and get paid for by the payers. And you have this constant tension going on. So to Steve's question about the consumer and who's going to pay for it, there are models afoot that are changing that dramatically that you'll see over the next 5 years that will deal with it. So I'll stop at this point, but the conclusion is that the present models that we have are going to evolve very quickly because we can't continue to do it this way.
I think you covered that topic pretty well.
Yeah.
But I'd like to ask Anthony, can you discuss potential drivers you see that could have like the frictionless interaction and the workforce limitation and how that commingles?
Sure thing. Thanks for having me here. Great to meet with these distinguished gentlemen tonight. So first, I'd like to make a comment on the example Jeff gave, Dr. Cohen gave on the Medicaid population. So in my background, we serve a lot of patients with COPD. These are really the drivers to increase costs within the healthcare system. Many folks don't realize that they're the third costliest population in the United States, if not the world. Yet, from a socioeconomic standpoint, they may not have the resources to take advantage of some of these direct-to-patient, direct-to-consumer, some of these self-management tools that help improve their lifestyle, help them quit smoking if that's the cause of their disease. However, if we were to think more broadly about the care of that individual and outside of the hospital, many of those COPD patients have a caregiver who is covered by a self-insured plan, who could activate could provide education support for that patient and be reimbursed through their own self-insured employer. So there are opportunities for direct-to-consumer, direct-to-patient, if you will, through the informal caregiver for some of these populations as a way to mitigate the costs. In terms of the drivers of future healthcare, who pays is definitely going to dictate how the healthcare landscape is going to shape up. But as I think about digital health platforms that reduce the friction to access care and provide a lower cost to the payer and or drive referrals to the health system for patients that they may want to see, that's going to be a key theme and key driver to the future of healthcare. I also think about the continued limitations of the workforce as a driver to the evolution of healthcare in the United States and really driving more of the healthcare system to either hospital at home models or managing more of the patient interactions in the home, either through telemedicine, through patient engagement solutions, and or different diagnostic procedures.
So, Dr. Saltman, can you, again, as we define healthcare as who pays for it, can you expand on today's issues with payer reimbursement and insurance? And how does that work in today's system? And then how do we change it?
Yeah, well, thank you for inviting me here and this esteemed company. Just rolling even back a couple questions, right? I mean, the consumer really, we're in this room thinking that the consumer is the patient, right? That's what everyone is assuming. The consumer is actually not the patient. The consumer is actually the physician, because you go to the doctor, the physician orders the test, the physician orders the medication, the physician admits you to the hospital. The patient has been very passive in this. And as a matter of fact, the patient has no idea what these things cost. They get a bill. You hear stories all the time about patients. Oh my God, I saw the bill from the emergency room. I can't believe it was $40,000, right? There was a study done at the Brigham and Women's Hospital when I was a resident, which was a long time ago. It was in the 90s. And what they did was they made the medical residents aware of what they were being charged for various tests. If you ordered a blood count on your patient, that was $7, et cetera, et cetera, et cetera. When they made that information available to the residents, the cost of taking care of patients went down by 70%. So the lack of awareness, all these levels of insulation that have been built into the system create these inefficiencies, increased cost, et cetera. Also, when I was training, you wanted to get patients who had commercial insurance because it paid 5 times what Medicare pays. That's not true anymore. Now those companies have negotiated down to being, if you call Medicare par level, it'll be 110% of par level, sometimes even 90% of par level. So now everybody wants Medicare patients because you get paid, there aren't any questions, and you move on, unlike commercial insurance. So the system has to change. And I know you have a question going forward about who's going to pay in the future.
Right.
Yeah, to be honest with you, in the long term, it's going to end up being the government paying, because the construct we have now, which Dr. Cohen said, is not sustainable. We continue paying more and more of our GDP. Out of all of the countries, out of the 14 what's the word in the United Nations uses it, the OECD. Out of those 14 nations, we have the worst outcomes in every single category. And you probably read an article just a couple of days ago. The maternal death rate is rising in this country. I mean, what is going on, right? We are not getting value for what we are paying. So the system's going to change. And it has to change in the sense that the consumers need to be aware of what they're paying. They need to be aware of what they're getting. And we need to innovate to make things less expensive. And I would love to talk about, how that actually works with patients and stuff as we go on. Oh, okay.
Absolutely.
Continue. Okay. I'm on a roll. So I think that, we have, and you've heard, this is trite to say this, but we have not a healthcare system, but a sick care system, right? We don't prevent disease. We wait till patients get sick and show up. Well, there's a compounding factor to that, which is that we also drive care by the calendar and not by the event. And what do I mean by that? You go to the doctor, you have, let's say, COPD or heart failure or a chronic condition. The doctor says, here's your medications, go home, I'll see you in a month. What is magical about a month? They never taught us in medical school that disease happens according to the calendar. The patient gets sick before their appointment. What do? They call the emergency squad and they go to the emergency room and they inflict tens of thousands of dollars because of that kind of behavior. Where does innovation come into this? If we can move monitoring of those sick patients into the home and somehow ingest that huge amount of data that's going to be coming and make sense of that data so we can intelligently monitor those patients and say, Mrs. Jones, you're fine. You don't need to see your doctor. But Mr. Smith, you're getting sick. You better get in the car and go see the doctor today. Now we've increased the efficiency of the system. We decreased the costs. We do event-driven care instead of calendar-driven care. Now, we need the tools to do that. We don't have the tools to do that now. We know that if you, what we call high touch, if you take care of patients more frequently, you call them all the time, you ask, how are you doing, et cetera. We know those patients do better. We don't have enough arms and legs in the healthcare system to take care of the patients like that. That's not a sustainable solution, but it tells us that's where we need the tools of the future. That's the gap that we need to fill. How do we monitor patients intelligently? How do we raise an alarm when an alarm needs to be raised and not have people coming to the office every month just because it's the 4th of April or whenever their appointment is, right? That just doesn't make sense. So anyway, I've exhausted myself for the moment, but I hope I covered some.
Dr. Cohen, do you have any insight into that you want to add?
Sorry?
1 second.
No, I'm
Oh,
sorry.
okay.
Over here.
No, he was taking my pulse to make sure
Sit
I'm
back,
still
sit
alive.
back.
So, yeah, where's Danny Rosen? There he is. So Danny's going to talk about his idea about how to do this. I'm going to start with this, is that the people that are sitting in this room, no matter what disease you have, you're going to do fine. Okay? When we look at the outcomes, it's economically segmented. It just turns out that minorities are poor. And when you look at the economic segmentation of outcomes, it's pretty impressive. So if you look at it from the standpoint of a commercial insurer, UPMC commercial, Highmark commercial, why isn't everybody like this? That was a question I had. Why isn't it like this? And then you start looking at the utilization, the outcomes of the patients, and you break it down into Medicaid, commercial, Medicare Advantage, and fee-for-service Medicare. You see some very stark outcome differences. And from the standpoint of getting in front of it, there's no money in the fee-for-service system of preventing people from coming into a hospital. So are the doctors and nurses aware of that? Absolutely not, okay? The ethics of healthcare are such that if somebody shows up, you don't do a wallet biopsy before you take care of them. You take care of them, okay? And then a hospital president comes and bitches you like, why can't you get these guys out of here? Well, the answer is they can't because they don't respond the same way. It's a fundamental question. So as you're designing the companies of tomorrow, don't think about the commercial market because they're going to define whatever you do. Think about the people that live in Bellevue or the north side of Pittsburgh or Homewood. Is that the issue there is much more fundamental and there's an impact that the environment has on the host where they don't respond as well. So Dr. Saltman's a bit older than I am. And, we grew up at the same times of training.
I am?
Yeah, you are. For purposes of discussion, you are. How many of you have ever read the book, The House of God? Just raise your hands.
Oh, my God.
So it was a parody about being a house officer in the late 70s and the early 80s. I'd urge everyone to read it to understand what really goes on within hospitals. So this idealized view of this is that you have control of everything. Yeah, no. And the reason I asked Danny to raise his hand is that he's part of the answer of where the future is that The problem with healthcare is not a healthcare problem. It's a social problem. It's poverty, it's housing, it's food insecurity, it's education. And if you're going to fix the problem of healthcare charges, the social domain that all of these fit in, healthcare, housing, et cetera, is the causation of why the patients that come in the emergency room on average 8.3 times a year get admitted 50% of the time, which means if I'm losing $5,000 every time they come in, I lost $40,000 every time that patient shows up in my emergency room, where the hospital's closed, poor neighborhoods. Why? They don't have the income that commercial insurance has. So don't think of healthcare change in the commercial world. Think of healthcare change in a much broader context of the social missions that all of these entities fill. If you're going to change healthcare, you better be prepared to change the communities they live in, job creation. And I used to be a Republican. I'm not sure what I am now. I'm a socialist or a Marxist. But from a hardcore, genteel surgeon, he's a cardiac surgeon. They're just a pain in the ass.
Not genteel, no.
You're kind of gentle. Anyhow, long story short is that it's a much broader question that the key to innovation is the first question. What is the problem you're trying to solve?
Mhm.
And in this situation, the goal of innovation is the problem with healthcare is the human condition that we have and the unintended consequences of the change of the 20th century to the 21st century. Danny has part of the answer, so listen to what he's talking about. You can send a check to the house.
So one of the things to kind of take a tangent here is, again, we're back to who pays for it. And Anthony here works with Philips and has some experience with different ways of paying, right, through insurance or private pay. You want to go into a little bit of that?
I do, definitely. Thanks for that. Just one point I want to make beforehand, the sick-based care. So that's not to say that there aren't reimbursement models for proactive care for individuals in the home. There's remote patient monitoring codes, remote therapeutic monitoring codes, relatively new in the medical world. I think these came out in 2019, right before the pandemic. There hasn't been this great adoption because of, I think, trust, right? From a physician community standpoint, from a clinical evidence standpoint, but it's a step in the right direction to have the right economic incentives from a physician community standpoint to be more proactive. Now it's about engaging the physicians in the clinical community to include that as part of their scripting process. Right now it's reactive. You have these virtual health companies that are trying to reach out through consumers and tell them, hey, you need to be part of an RPM program. And they're like, I don't know you, I don't trust you. Let me ask my physician. So we've got to embed that decision-making process for specific conditions and when appropriate. So it's coming from the clinical community, and that's where you're going to see the adoption more so. From the question about who pays, it's a mix of both. And I think other folks in this room probably had the same experience. I was diagnosed with obstructive sleep apnea, and I was given a path to go to a sleep lab, spend the night at the sleep lab, wait 3-4 weeks to get into the sleep lab. Part of it was covered, part of it was copay. I'm on a high deductible plan. So there was $700 to do that. Once I was positive, I knew, because I was in the industry, that I could pay as much as $1,300, $1,400 for the medical device, and then anywhere from $400 to $500 a year for the consumables. I took a step back and just considered my own opportunity cost and really the requirements of the healthcare system to be compliant, interact with the physicians, mandated, ensure that I'm benefiting from the therapy. And I chose to go a direct-to-consumer route. So once I had my script, reached out to some online CPAP companies, had a telemedicine visit, was provided my equipment within a couple days instead of a couple weeks or months, and streamlined the process to therapy. So did that cost me several $100s out of pocket for the diagnostic as well as the therapy? Certainly. But the ease of that interaction, the less friction from my own patient experience, made me choose to opt out of the reimbursement pathway. And I think many of us could have other examples, whether it's a telehealth visit for general wellness, some type of diagnostic treatment. There's options there where we may choose, albeit we're in the right socioeconomic group, to pay out of pocket with an HSA or FSA and go around the healthcare system itself.
So as we lead into that, with higher co-pays, the economics of healthcare is getting difficult. right? Yeah, who pays for it? How can I afford it? Dr. Cohen, could you explain a little bit about the ICHRA and how
sir.
that is changing a little bit and having impact?
Yeah, how many have heard of ICRA? Wow. So the group policy is based on a massive contract that covers all the employees of a company. ICRA is an individual compensatory health reimbursement account. What does that mean? If you're an employer, you'd establish a benefit for your employees. And let's say your employee benefit is $600 a month. Okay, so I'm going to give you $600 a month and you go get your own health care. Go on Penny in Pennsylvania, or the individual policies are available. If you're 26 to 46, you need a catastrophic policy, because most times it's having a baby, it's, the rare event, it's an accident. So you're better off having a high deductible policy to cover catastrophic illnesses. What's that going to cost you? Less than what the benefit usually is. What do you do with the money? You can put it into a qualified plan like an HSA. So if you're 26 and you're doing this, and let's say it's $300 to get a policy. I have several millennials that teach me how to speak millennial, but they're cheap. Okay, so they want the money like everybody else. So they bank the money. They're putting away $3,500 a year as an individual in an HSA. By the time you're 46, they have 75 to 100,000, depending upon the market and what they invest in. When you're buying it and it's your money, all of a sudden it changes. So we actually did this at our company at ChemImage because we were faced with a problem. And the problem was one of our employees got deathly sick. She ended up at McGee. They saved her life. And the bill for that was somewhere north of $2 million. We were told by the carrier at that time that we were going to get a 40% increase a year for the next 3 years. At that point, we were paying about $10,300 per covered life in the company. And each employee out of pocket was spending about $3,000. We had no choice because we couldn't afford it anymore. So we found this, and it's a tax law change. In 2019, it was activated in 2021. We did it in 2022. If we had stayed on a group policy, I would have ended up spending at least double, if not more than that, on a group policy. So we put it in. The first year we put it in as an employer, we saved 22%. We told the employees that we're not going to keep the 22%. We're going to give it to you. Everybody got $1,600 in their HSA and a 4% raise. They're pretty happy. The thing that we found was that when we got to the end of the year and we looked at the numbers, the consumption of resources went down by about 70%. So the out-of-pocket expenses in the group plan was about $3,300. At the end of 22, the out-of-pocket expenses was $1,100. This year, we're covering it with about $9,200 per life. This is now 3 years later. $1,600 of that $9,200 goes into an HSA. So the medical expenses went down to about $7,600. What does that mean to the payers? Life's about to change. Okay. What does that mean to the employers? Yeah, because there's only two things an employer wants to know: how much and how little bitching can I get from the employees? Okay. How about the employees? I get to choose, so I don't have to listen to, I really want to go to UPMC, or I really want to go to Allegheny. Go wherever you want, get the policy. But the evolution of this out of the 50s with the group policies, we now have a crisis in funding. It leads to innovation. The innovation is going to change the way we pay for things. So in Anthony's model, he's going to ask the question, do I really need a sleep lab? What about these at-home tests? How good are they? Is it going to solve my problem? So when you're paying for it, it changes. And the disintermediation that we have today of the patient only paying a fraction of the cost is about to change. And as you align the payment system with the consumer, you now have the beginnings of a pricing mechanism that's effective. Because if you need an MRI, are they really that different at AGH than they are at St. Clair, or they are at, North Hills Pat? The answer is no. There's only 3 people that make the machines. Okay, they're about the same. They're commodities. And if you look at the inflationary costs over the last 20 years, this is the stuff we do regularly. Healthcare and education the rise in rates exceeds the GDP by an enormous amount, and it can't continue. So I'll stop there, but it's called ICRA, ICHRA. It's a tax law change. I'm impressed that one guy understood what it was.
I had HR, so.
Can't know
So
better
with this
than
group,
that.
we could be up here for about another week. I had another like 100 questions, but I don't think we're going to get to them. The last question I have before we try to have a minute or two for questions is the fact that we know that this crisis for fee-for-service medicine is happening, right? Looking at value-based systems are critical for future care. So how do we, each of you, how do we see this playing out over the next 3 to 5 years? And how does that impact development of technology? Kind of summing that up to our discussion today. We'll start with Anthony.
Sure thing. So as part of my role as a solution leader with Philips, we've created different solutions to sell to hospital systems, sell to payers that really spoke to the value-based care. And, you know, when you get to this point of trying to prevent a preventable readmission for a COPD patient, CHF patient, prove out that they're more adherent to their therapy and thereby reduce the systemic cost of the hospital, that's all well and good. But whenever we got to the value creation or the value sharing model, there wasn't a desire to share in those savings that you were generating for the hospital system. There was more desire to move to a fee-for-service solution for the solution provider to lock in a fixed rate, and then they would keep those savings. So at least in my experience, I haven't seen that change in terms of the hospital systems, the payers wanting to share in the value-based care, and driving more of a fee-for-service model for the providers themselves. The other element is just the severity of the patient. I think of what we would call the living well patients, there's not as much value for a healthcare system to identify those patients and create this value-based care model. I may switch insurance providers 5, 6 times. So there's not the same care. So for commercial pay, I don't see it changing much. For Medicare, Medicaid, maybe there'll be more motivation to drive value-based care adoption in the future. But I've yet to see it in terms of creating a virtual first or remote digital health solution and try and sell that to the hospital, and then having the opportunity to share in those savings yet.
Dr. Saltman, what do you think? Where do you see this going?
Well, I agree with what Anthony was saying in the sense that the way the system is set up now, there's no incentive to switch to a value-based structure because value-based basically puts the risk on the provider. They give you a bag of money, and then you have to spend as little of it as you can to make a profit. It's not like you are billing for piecework, like in fee for service. And if people are changing insurance companies all the time, the insurance companies aren't incentivized either because most of the value-based care benefits are seen over years. And so you change every 2 years, you know, the payer doesn't see that either. So that's why I think one of your questions was, who's going to eventually pay for all of healthcare? And I think it's going to be the government. And I may have said that before, but when you look at the Medicare population, for example, they are on Medicare for a long time. And so the government will become the center to drive innovation. I know you'll throw eggs at me, but but really when you think about it for a second, just think about it for a second. How did we get to the moon? The government paid for that. Okay, how did we develop all kinds of technologies? The government paid for it because they have the 5-year, 10-year outlook. I mean, I lived in the research world in academia for a long time. I got government grants so I could do projects that would yield fruit 5 years from now, 10 years from now. They're, VCs, no insult to our first speaker, VCs are much interested in the shorter term. And so to come to market with something that is going to take 5 years or 10 years to impact healthcare, you need a longer term perspective on that. So I think, where is the system going to go? I think it has to go to a value-based system. I think that some of the savings have to be put into innovation. That's going to be a longer term prospect. You're going to have to fund people who have a 5-year vision or longer than that to get those kind of products on the market to eventually make care cheaper and more effective. Now you can fight with me. Go ahead. Go ahead.
And now let's look at the other view.
I wore my Kevlar vest. I'm ready.
So the hospital was the center of gravity for healthcare distribution. Contrary to my esteemed colleague, the government already pays for most of healthcare. And that 51% of it is either Medicaid. By the way, prior to the pandemic, there were 65 million lives on Medicaid. Today, there's 90. One for Medicaid, one for Americans is on Medicaid. That's a value-based system. Number two is the center of gravity today is the web. And in a value-based system, the web is the tool by which you can get predictive analytics that tell me who's going to get sick and try and front run that and solve the problem before it occurs. Whether I want it or not, whether it evolves into a government-funded NHS, which is similar to the rest of the world, or it's an American system where the individual decides the consumption levels of what they want, will play out in the economics. And of the $4 trillion, how do we move this model forward? So I'll just summarize and say what I think is going to happen and what will happen are two very different things. But look at the steel industry and the disruptions that it caused, through the 70s and 80s in Western Pennsylvania. The Rust Belt will now become the Water Belt. And innovation, the bedrock of healthcare change, is actually in Pittsburgh. And it started in '98 with the AHRF bankruptcy and the evolution of UPMC. And you have two very large integrated carriers. They're both legacy systems, and they're both ripe for disruption. And they're both taking steps to try and figure out where to go. So like all innovation, when we look at companies to pick for Alpha Lab Health, we start with, how are you going to solve problems in healthcare? And what is it about your technology that's better, cheaper, and faster than what we're doing today? Answer those questions, and we're interested. So I'll stop there.
So we've exhausted our time. I really appreciate it, and thank our guests and our panelists.
Thank you.